Now the camera is open, so as the webinar is for all around the world, so the language is English. So in behalf of the Brazilian Society of Functional Neurosurgery, I'd like to thank everybody for in our series of webinars. The audience has reached a good number of people all around the world, as I said. And all the lectures have been really great. So today our topic is neurosurgery for psychiatric disease, and Dr. Paul will present the speakers and the panelists. Okay, go on, Paul.
Welcome to everyone. I would like to thank you all for being here today and say how important is your participation. Well, today's topic is very special. Despite effective therapies, at least 20% of OCD disorder and mood disorders remain refractory to treatment. Since the eminent physiologist John Fulton provided a framework for understanding that intellectual and affective functions can be anatomically pinpointed, thereafter neurosurgery for mental disorder became a new successful tool, but its continued use depends heavily upon both the evidence of benefit and the absence of harm. The current age of neurosurgery for mental disorder for otherwise intractable cases is exciting, with developments in imaging, neurophysiology, hardware technologies, allowing for the understanding of each target condition. To talk to us today, we have a selected and important group formed by Professor of Neurosurgical Science. The panelists: Professor José Osvaldo is head of the Pain and Stereotactic Center of the Hospital AC Camargo, coordinator of Functional Neurosurgery and Pain Treatment Center of the Hospital Servidor Público Estadual de São Paulo, Brazil. Professor Luiz Modesto is a neurosurgeon at Hospital Santa Luzia and Neuromed and Neurofuncional Clínicas, Brasília, Brazil. And Professor Rodrigo Labruna is a neurosurgeon at Biocor Hospital and Vila da Serra Hospital, Belo Horizonte, Minas Gerais, Brazil. Many thanks to everyone for accepting the invitation for Brazilian Society of Functional Neurosurgery. Our speaker. Well, Professor Clement Hamani educational background includes medical degree and PhD from Escola Paulista de Medicina, neurosurgery medical residence from Universidade São Paulo, fellowship of functional neurosurgery from Toronto Western Hospital, University of Toronto. Professor Hamani currently serves as now senior scientist, biological science, Hurwitz's Brain Science Research Program, Sunnybrook Research Institute, and is a professor of the Department of Surgery, University of Toronto, Canada. For many years, I observed that many people break an unwritten the rule and call Professor Hamani by the first name, Clement. Perhaps I can quickly explain why. The name Clement means gentle, merciful in character. What does Shakespeare say about Clement? In the Act 4 of the Merchant of Venice, Portia says that merciful character is a tender and a noble feeling. We learn that justice and mercy are complicated because the idea of mercy seems to accompany every moment of justice. Shakespeare won't give you one without the other. This is Professor Clement. Clement, the stage is yours. Break the leg.
Let me share my screen and see. Okay. Can you guys see my screen now?
Yes, it's working well.
Hello? Paulo, can you see my screen?
Sim, nós conseguimos ver.
Ah, tá. Eu não estou ouvindo. Well, Paulo, thanks very much for the very kind words. I have no words to thank you. I would like to thank the Society for the invitation. I'm enjoying very much the series of talks that are part of this Masters of Functional Neurosurgery. I've been listening to the ones I can. I've been learning a lot. I think Brazil had a very nice way of dealing with the time of I think isolation during this pandemic by organizing a series of talks that on different topics. The Brazilian Society of Neurosurgery, the Brazilian Society of Functional Neurosurgery, and other societies, SONESP. I've been listening to a lot of talks and learning a lot from them. Not many countries organize such great talks. So when Paulo invited me to talk, one of the topics that I suggested was new trends in psychiatric neurosurgery. And I acknowledge that Ludwig Zrinzel gave a similar talk before. So I wanted to organize and put together something that was slightly different from what he already told you. So he focused a lot on obsessive compulsive disorders and lesions and some DBS work. So I'll talk about 3 different topics that I'm gonna discuss now. So I have no disclosures related to this topic. So the topics that I'm gonna discuss are is there hope for DBS in depression? As you guys know, there are 2 negative recent trials, not so recent, but 2 negative trials, and how the field is reorganizing after the negative results of these trials. Then I'm gonna show you a little bit of work that we're doing at Sunnybrook with deep brain stimulation for post-traumatic stress disorder. And I selected them, this topic, because it's a process and a procedure that or an application that was born from work in my laboratory. So I'll try to show you how translational work in the lab can be used to develop new treatments or treatment modalities for DBS. And then I'm gonna discuss some ablative procedures that we're doing at Sunnybrook, mostly with focus ultrasound for OCD and depression. So to start with depression and why do we think there's still hope in the failure of recent clinical trials? So this is initial work of DBS in depression in subgenual cingulate gyrus, or subgenual cingulate region, as you will. So this is seminal work by Helen Mayberg. You guys saw the slides many times. There's an increased activity in this region in patients with depression. And one interesting aspect of this work is that the first paper that was published in Nature, the one that where this figure comes from, it was quoted over 2,000 times already. And this is because I think it was one of the not first, but it was a very elegant example of how you can do translational work. So from neuroimaging studies, you develop a hypothesis and then you test whether your surgery is going to do the effect that you want based on your hypothesis, and you're going to come up with a conclusion. So it was a very elegant work, and that's why the study is so quoted. Initial studies, as you know, were very promising, over like 50–60% of response. Prolonged responders, like 3 years, 4 years, 7 years down the road, people still respond to surgery. All open label studies. This was very promising. It attracted a lot of attention, especially from industry. A lot of investigators jumped into this. I was one of them that was very excited when I saw a few patients. I can talk to you during when we were answering questions about our experience here at Sunnybrook with some of the patients with depression. And this motivated the development of new targets for depression. So Other groups investigate the effects of anterior capsule nucleus accumbens or the iliac anterior limb of internal capsule for depression. Same thing, 50% response at the long term, meaning that out of 100 patients that you treat, so a patient comes to your office, you can say, you have a 50% chance of getting better. You were treated with several medications, psychotherapy, you didn't get better. Now with DBS, you have a 50% chance of getting better. So this was very promising until blinded studies came up. And in blinded studies, and with DBS, you can do this very interestingly because you can implant electrodes, get one group of patients, turn them on, get the other group of patients, keep the electrodes turned off, and then you compare the outcome of on versus off. I can also discuss this later, why I don't think it's a very good idea based on what we know now, not what we knew then. But the fact is the two blinded studies that were conducted, or the multi-center studies, this one was anterior limb of the internal capsule. You can see not a lot of difference between patients who received active stimulation versus the control group. And this was another study that was negative and was part of the study. And this was the subgenital single DBS, the broadened study, and patients who received stimulation versus patients who did not receive stimulation. No significant differences during the follow-up of the study. This was the blinded phase, and this was the open label phase. One remark is that during the open label phase, 40% of the patients were responders. So 48% at 2 years. So the numbers grow with time. Risk cost growth gave this talk, I think, in the Brazilian Society of Neurosurgery seminar that was an excellent talk, actually. And he said that the benefits of psychiatric surgery, they're not only sustained over time, but they tend to grow over time. And this is something we see, I think, systematically with lesions and DBS. I mean, patients who respond, they tend to get better over the years. So this is not unexpected. So with all this negative data, is there hope? Is it all lost? I think there's hope, and I'll show you why. So there's some aspects supporting efficacy and the development of new studies. So we wish for a successful comeback. So what about target? Can we improve targeting strategies so that our DBS is better than what we used to do before? I think we can. This is a very good, very elegant study by Patricio. Patricio was also a moderator when Reese was giving his talk, and I know him very well, and he works with Helen at Emory, used to work, because Helen now is New York. So they characterized what they call the blueprint of fibers using tractography. And this blueprint of fibers is basically a confluence of fiber tracks that cross the subgenital region, and they project through the cingulate bundle to the cingulate gyrus, via the forceps minor to the frontal cortex, uncinate fasciculus to the amygdala and temporal lobe, and to some subcortical fibers going to the striatum, nucleus accumbens, and thalamus. So they claim that if your electrode was within the blueprint here in the center, so this is the volume of tissue activated, the green sphere here would be in the center of the blueprint, your effect would be from a 50-60% of response to 80% of response. So you jump 20 or 30 points in terms of response. We've been doing tractography here at Sunnybrook, and I can tell you, I discussed this with Helen a few times, and to me, it didn't make sense that moving 1 millimeter here, 1 millimeter lateral, medial, anterior, posterior would make a big difference. But I can tell you, if you move 1 millimeter, sometimes you lose a fiber track. Sometimes you go 1 millimeter more lateral than the blueprint, and you lose the forceps minor. Or you go more anterior, you lose the cingulate bundle. So playing with fiber track, I think she's onto something there. And 1 or 2 millimeters make a bit of a difference here. This is a sort of a new set of studies. It's not that new anymore. So this is spearheaded by Volker Konen. Volker is a neurosurgeon in Germany, and Thomas Schlaffer was a psychiatrist working with him at the time. And they characterized the target that they called medial forebrain bundle. There's a sort of a controversy in the literature where this is actually the medial forebrain bundle, but certainly the fiber is there. You do tractography, you can follow it. If you can call it medial forebrain bundle or not, it's probably not that important. It is important, but the fiber per se is there, so you can easily find it with tractography. So they characterize this fiber track, and Volker is doing a very elegant series of studies trying to establish a better target and optimize this and doing tractography, very elegant work. So I really recommend the reading of his series of papers. So he placed electrodes in what he called medial forebrain bundle, or the supralateral branch of the medial forebrain bundle, which is close to the medial border of the STN. Here you can see. And what he found was a strikingly acute antidepressant response. So the patients were, this is a MADRS score. It's a different scale that people use to measure depression. And you can see that patients were immediately better over days of stimulation. And this is something that we didn't see with subgenual cingulum stimulation. So this was received with a little skepticism, but with a lot of promise, because you would have a therapy that would lead to a very acute effect and that was sustained over time. So this was great. So 7 patients, they replicated in a few more patients. There was a group in Texas that got similar results to some extent. So we decided to try this at Sunnybrook, and we implanted 2 patients. We were going to implant more, and we got discouraged by this result. So we implanted 2 patients with electrode close to the medial forebrain bundle here, as Volker defined in his papers. We recorded a similar pattern, side effects, ocular side effects, and so forth. We didn't see any effect in neither of the 2 patients treated. So we did an on and off blinded evaluation. So patients after 24 months of stimulation, they would be blindly turned off or remain on, and then a small crossover of 2 weeks. Also here, we didn't see much. So in our hands, in these 2 patients, medial forebrain bundle did work very well. That said, I know of 2 or 3 investigators around the world that tried medial forebrain bundle stimulation. They were very, very encouraged by the results. They asked me, why do you think your results were negative? I don't know. Sincerely, I don't know. But still, I mean, controversy is there. But the medial forebrain bundle is probably one of the most promising targets to date for DBS in depression. So designing novel clinical trials, is it possible to improve clinical trial design so that we get a better response in depression from now on? So far, the trials that I showed you, the blinded ones were half of the patients turned on, half of the patients turned off, and then you compare them, and then you do an open label afterwards to see if patients get better. So another thing that we need is predictors of response. We have no predictor of response today. I'm going to show you one example, but we don't have anything useful so far. So this is a predictor of response. So Tejas was he's a surgeon in Edmonton here in Canada. He was working in Toronto when he did this paper. And this is just an example. So cortical thickness analysis, VBM, voxel-based morphometry. And you can see here that responders, they have a higher subgenual cingulum volume compared to non-responders. Or the hippocampus, they have a higher volume of the hippocampus, or more pronounced thalamus. So this is the kind of analysis that if you establish a threshold, you can go back to the preoperative period and say, okay, so this SCG is very thin, so the patients may not be a good responder. So far, we don't have this data, but this is where this kind of analysis may go. There are several other markers we can discuss later. So trial designs, blinded phase only responders. I think this is very nice. I used to criticize this kind of design, and I was mistaken. And I grant this is to me, it didn't look like a good idea in the beginning. Now I think it's a very good idea. So this is the first study of this kind that I'm aware of in depression. It was a study published in Barcelona. And what the patients did, they included patients who achieve a stable clinical remission with continuous stimulation, okay? So they treated 8 patients, they only included 5 in their study. And what they did here is that they only got responders. I'm just gonna focus on this graph, okay? So they excluded non-responders. So when you have 5 patients who responded to DBS, what you see is the following. Pre-op, their Hamilton is very high. Pre-randomization, so they respond to DBS, so they drop their score. When you do an off versus on stimulation paradigm in patients who responded to DBS, you have a positive response. So in the off stimulation, the patient gets worse. In the on stimulation, the patients get better. So that means that probably there's a subpopulation of patients that we cannot identify so far that respond to DBS. And when you get these patients, when you do an on and off stimulation paradigm, they do respond. So the question is, how are the responders different from non-responders? That we don't know. So this is another study that followed this kind of paradigm, and this was done in the Netherlands. So the same story. So the patients, they got a pool of patients, 16 patients that were treated with DBS. This time was the ALEAP, the ventral anterior limb of the internal capsule. And they got the patients stimulated for approximately a year. And then they subdivided the patients in responders and non-responders. Here you see the mean of the patients. Here you see non-responders. You see their scores are basically unchanged from baseline. And then you see a group of responders here. Those are our 16 patients that were responders. So then you can see here that the patients, they dropped their score and they were considered responders. They had a 50% or better improvement in scores, okay? So when you do discontinuation studies, blinded, sham versus active stimulation, the patients are blinded. When you do them in the whole group, you don't see much. When you do them in non-responders, here the orange triangles, you can see that the scores during sham versus active stimulation don't change much. But when you do this in responders, the patients who did respond, when you turn them off, they get worse. When you turn them on again, they get better. What I mean is that there's a subpopulation of patients that do respond to DBS, and we just have to characterize these patients. This is very important, in my view, before we start doing more randomized clinical trials that cost a fortune. It's like, suppose you're operating on a patient with Parkinson's. Now we know that patients who respond to levodopa, they do much better than patients who do not respond. Imagine that you include in your trial all sorts of Parkinsonism patients. So all sorts of patients with PSP and multiple system atrophy and Parkinson's and non-responsive to levodopa, your trial is likely going to fail. So if you don't select patients who are good responders to levodopa, you're not going to have a good response. So I think this is key in depression now. So how do I identify these patients? And I think if you come up to the conclusion of who are these patients, and that with the optimized targets that we have now with tractography, then you have a new chance of having this succeed. So just to finalize this part, this is a very elegant study by Dr. Machado. So Andrea is well known from all of you in the audience. And then he did this study for post-stroke pain. It has nothing to do with depression or anything like that. But the idea was to treat the affective components of pain. And what I want to call your attention is that they didn't see much in their primary outcome, which was pain, or the affective components of pain. But when you look at some of the depression scores are much better in the on stimulation versus off stimulation. And this is blinded, right? So in the blinded crossover, when patients received active stimulation, they were much better than were off stimulation. So this also shows that this may work. So in other words, DBS may work for depression. So future directions, this first third of the talk, I think more studies are needed. I wouldn't jump into a big blinded randomized clinical trial now. I think we need to further characterize predictors of response and understand what is that population. So how do we differentiate that population of patients who respond to DBS from those who do not respond? I still don't know. We may have to learn more about effect size, time frame for optimal response. As I told you, the patients get better over time. So you have patients that start responding at 6 months, start responding at a year. You see this in OCD, you see this in depression, certainly in several psychiatric conditions. I think that this has to do with neuroplasticity of the brain. Okay, so now applications. I'm going to talk to you about PTSD. I really like this subject. So I'm very biased. So I'm gonna, and it's the only time I'm gonna talk to you about rodent studies. And this is because it came out of my lab, and I was very enthusiastic about this work when I first saw the results in rats. So you have patients, or you have people that are exposed to stress all the time. So violence and crimes and sexual harassment, you can read the news, this is all over the place. And usually these people, or like everybody that's exposed to stress, develop an acute stress reaction. This is very normal, right? So if you don't get better by yourself, you take medications, you do psychotherapy, and most people, or 80% of the people, are going to recover, okay? But you have 20-30% of the patient of people who are exposed to an acute stress response, and they not recover. So they ended up develop post-traumatic stress disorder. These numbers vary, but usually 20% is a good mark. So of all people who are exposed to a stress, and the most serious the stress or some form of stressors, they tend to do more harm than others. But some people develop post-traumatic stress disorder. So keep this number in mind, 20%. So what are the neurobiological framing of PTSD and fear and anxiety and so forth, and control and resiliency? I'm just going to show you two basic structures. So the basolateral amygdala and medial prefrontal cortex. So when you are in danger, or when you are experiencing fear, your activity of your basolateral amygdala or your amygdala in general goes up. Okay, so you have an increased activity of the amygdala in detriment of a reduction in activity of the medial prefrontal cortex. On the other hand, when you feel safe, the medial prefrontal cortex goes back and talks to the amygdala and say, calm down, everything is okay, it's under control, there's no need for an increased activity anymore. So danger has passed. So there's all this theory suggesting that top-down regulation of the ventromedial prefrontal cortex over the amygdala is very important for the control of stress, fear, and post-traumatic stress disorder. Okay, so I want you guys to keep this in mind. I'm going to show you two tests in rats that we routinely do in our lab here, and just to explain how I came up with the treatment. So this is called the fear conditioning, fear extinction experiment. So you put a rat in a box, and then there's a grid here, okay? And the animal explores. The box is in your environment. He's just there exploring. All of a sudden, you present the animals with a tone. So it's a beep, beep. And while the tone is ringing, the animal receives a shock in the paws here, okay? You do that several times. And when you present the animals with the tone again, the animal is going to present a behavior that's typical of fear. So it's going to freeze. Basically, it's like that flight or fight response. The animal just freezes when he hears the tone because he knows the shock is coming. So it's a sort of behavior that represents fear, if you will. So what you can do with this animal, you can expose him again to the same box and present just the tones without the shocks. So the first time you do this, when you ring the tone, the animal is going to freeze. But as you start ringing the tone more and more, and the animal learns that the shock is not coming, the animal starts to move again and explore the cage. This is called fear extinction. Okay, it's a learned behavior, and it contrasts a little bit with fear conditioning. So you condition the animals to fear, and then you extinguish the fear. This is called conditioning fear, conditioning extinction. Okay. This is a second test that we do in the lab, routinely do, and it's called the novelty express fear, novelty express feeding. You put the animal in an arena here, an open arena. The animal is going to find treats, so it's food. You can use rewarding food, like we use here cereal. So cereals, you can use Fruit Loops, you can use Nesquik balls or chocolate balls, anything you want. So you put the animal in the side of the arena, and the trick is the animal is going to explore the arena, find the food reward, and eat it. There's the anxiety component of a new environment versus the rewarding component of eating the food, okay? So the more anxious the animal, the less exploration and the less food the animal is going to eat. So the longer it's going to take for the animal to eat and go and eat the food reward. If the animal is not anxious at all, the animal is just going to go straight for the food, okay? So the more it takes for the animal to eat the food, the more anxiety the animal has. So what I found in the lab was that as in humans, when you expose the animals to shocks in the conditioning paradigm here, 80% of the time when you extinguish the behavior, they do well. So the animals, they learn that the tones and the shocks go together. Then you present only the tones to the animals. After you don't present the shocks, they're just extinguished as if the shocks were not there, and they just go ahead and they eat the food. So 70 to 80% of the animals, they have a normal extinction and normal anxiety responses. Similar to PTSD, to the slide that I showed you, we call these animals the weak extinction guys. When they are conditioned to the fear here, when they present or they're exposed to the stressful experience here, receiving the shocks, they never learn to extinguish the fear responses. So it's like PTSD. So they are facing a threat, they relieve the threat. So PTSD patients, they have nightmare, they have prolonged anxiety, prolonged fear. So these animals, they never learn to extinguish their fear. And they always, or they present a very prolonged anxiety behavior. They never go for the food. They take a long time to go for the food. Okay, this is just to show you that you can use this to do a DBS experiment. So I did a DBS experiment stimulating the prefrontal cortex of rats here. And as you can see here, this is the animals. You can see freezing levels here. The freezing levels are very high in the animals that have PTSD. When you do DBS, you decrease freezing levels or you decrease freezing behavior. And this is a control animal. You can see here a high time, like an increased time to eat that reward. And when you do DBS, you drop the time to eat this reward. So that means that if you stimulate the prefrontal cortex of that animal, the animal is going to have less freezing and less anxiety. So this means that I get an animal that had a PTSD phenotype. He had fear. He was anxious following a traumatic experience. When I stimulate the prefrontal cortex, I stop the fear response and I decrease the anxiety. So this was very intriguing when we saw this the first time. And the reasoning for that we're also explored in a few studies. So we stimulated the prefrontal cortex of a rat, and we did recordings, neurophysiological recordings from the amygdala. And you can see here that when you stimulate the prefrontal cortex, activity in the amygdala goes down. As you might recall from the previous slide that I showed you, when you have more prefrontal, less amygdala, you have less anxiety and less fear. So why does all this behavioral and rat experiments matter? Because treatments that reduce activity in the amygdala improve fear extinction and anxiety in rats, okay? So the point is, can we translate this to humans? As I showed you, you stimulate prefrontal cortex, reduce activity in the amygdala, you improve fear and anxiety in rats. Can we do this in humans? And if I haven't done it, I wouldn't be showing it to you. So we did an experiment and we treated one patient here at Sunnybrook. And this is a tractography of this patient. And the idea was to use a directional lead here, get the blueprint of Mayberg with one of the contacts here. This was one of the directional contacts. And you can see here the cingulate bundle, you have forceps minor, you have striatal fibers. But in the ventral contact that's also directional, we pointed all the electricity towards the lateral aspect of the brain so that we would stimulate the uncinate fasciculus going to the medial temporal lobe. In other words, we replicated exactly what we did in the rats. So we stimulate the blueprint of Mayberg, but we also stimulated fibers going from the frontal cortex to the amygdala. So the idea was to modulate the same circuit that we modulated in a rat in this patient with PTSD. Here you have the electrode implants. The electrodes, they are placed a little more posterior than the target for depression because I want to get more uncinate fasciculus than the other fiber tracts. And surprisingly, this is a PTSD score. The patient scored very high before surgery. 3 months afterwards, 6 months, she almost normalized her scores. Okay, so her PTSD is very well controlled now. She went back to school and her Hamilton dropped by 80%. So I'm just showing this because I was very excited. I just published this paper and it's a pure translational concept. So I got something that I found in the laboratory in rats. Fear circuits are very preserved across species. I could do the exact same paradigm in humans and have a very good result in a patient with PTSD. Now we're doing more patients we have a small trial going on. I hope next time I'll show you more data. What about lesions? So I like lesions too. I have to confess. So I'm just going to talk about ultrasound. I think Ludwig talked about radio frequency. Antonio's here as a panelist, so we can talk about gamma knife later. I'm just going to show you the ultrasound work that we do at Sunnybrook. Here's just an MRI with the ultrasound machine. You can see here the helmet. And this is how the frame is placed. This is a paper that was published very recently in Operative Neurosurgery by our group. So you can see here, patient head shave. We use a CRW frame here. And the frame is placed very low in the head. You put this rubber band here, so around the head here, so that this rubber band is connected to the helmet. And there's the degasified water that circulates between the helmet and the rubber band. And this is just to increase the sonication power. And the ultrasound, it emits 1,024 elements of ultrasound that are confluent in a single point, and that creates a lesion. You guys have seen this, at least this kind of talks many times. So this is how we do the targeting for capsulotomy. We did capsulotomy basically for depression and obsessive compulsive disorder patients. We usually go 7 millimeters anterior to the anterior commissure here. We go lateral. It's usually 12, 13 millimeters lateral. It's usually, I like to use this Y-shaped sort of image just to show how we target. It's basically in the confluence of this Y-shape image here. It's a little more closer to the anterior capsule than the Y-shape, but you have the anterior commissure here. When the anterior capsule just departs, it's not departing because it's going downwards, right? But when you find the anterior capsule here, that's where you're going to target your lesion. This is the coronal correlate of this point. And we usually do one lesion or two lesions, one above the other, depending on how big the lesion, how big a lesion we got. I have to say our lesions are smaller compared to the ones I've seen with radio frequency. And we didn't do big two lesion sort of sonication so far. So this was the first trial that we published. So we're exploring novel ways of doing this, but so far this is working to some extent, so we're sticking to it. This is one of the interesting aspects of focused ultrasound. So yeah, when you deliver the therapy, you increase the temperature of the target. You can do pre-lesions at 40, 45 degrees. This is similar to the pre-lesions that we do with radio frequency devices. Then you do the actual lesion. You have to hit above 50, 53, 55 degrees, and then you're going to denature proteins and you're going to create a lesion. One interesting aspect is that the ultrasound has a thermography. You can measure the size of the lesion as they're being made. So you can estimate the size of the lesions, and you can do as many MRIs you want during the ultrasound process. For example, you do a lesion, you think it's not enough, or you think it's enough, you can do always a T2 MRI and take a look and see if the lesion is being made or if you have any T2 signal changes. Okay, so this is just an estimate of a lesion, for example, in the anterior capsule. And this is a post-operative image of what a capsulotomy looks like. So you can see here the lesions in the capsule, here in the coronal. Day one, you see big lesions. 3 months later, you see small lesions. 6 months, you barely see lesions. This is similar to radio frequency. A lot of this work, I mean, even the previous paper that I showed you was done by Ben. Ben is a PhD under my supervision in neuroenhancement. He's a really bright student, and he conducted this clinical trial here. Was a two phase one trials, I'd say, because we had mixed patients with major depression and OCD in the same study. These graphs are not in the trial. It's just the trial shows tables. I think in a graphic format, everything becomes more clear. We have 6 patients with OCD, 6 patients with depression. These are white box scores and Hamilton scores in patients with OCD. You can see that the scores are reduced by 35%, more or less. And patients in Hamilton scores in patients with depression, they had a drop in score by 25%. So if you consider this is a sort of a positive response, because 33% is usually a positive response in OCD. This is not a positive response in major depression because it's usually 40 or 50%. Okay, so what we found, in other words, is that in OCD, you have a better response to capsulotomy than in depression. So here you can see a little better. So non-responders in red, responders in blue. In OCD, out of the 6 patients, 4 were responders, 2 non-responders. In depression, the ratio was the other way around. So 4 non-responders, 2 responders. So in my mind, according to what I've seen, I've been following these patients, and we have a very cool clinic here at Sunnybrook. We have a psychiatric clinic, and we see patients every other Thursday, all the patients with psychiatric surgery. So what we've been able to track and follow is that I think, in my view, patients with OCD, they respond much better to capsulotomy than patients with depression, at least in the small cohorts of patients that we've been treating with focused ultrasound. One interesting aspect, and Ludwig mentioned this, and I commented on that too, we've seen no cognitive adverse effects. In any of the patients we treated, none of them developed cognitive adverse effects. Some of them are slightly better because of the improvements in OCD and depression, but certainly what people claim in the past, oh, cognitive adverse effects, etc., we haven't seen that with capsulotomy. So as we engage more in this less invasive therapies in terms of incision, so gamma knife, ultrasound, and we start doing neuropsychological exams, and those therapies are going to allow us to do that because people are more favorable in terms of delivering those treatments in clinical trials, I think, compared to previous lesion procedures. I think we're going to be able to explore more and more adverse effects of capsulotomies and cingulotomies and so forth. So far, we haven't seen major cognitive adverse effects in after capsulotomy. This is an interesting study that Ben did. It's in that molecular psychiatry paper. He got the lesion profile of the patients in our trial, and he got a normative atlas here and a DTI normative atlas just to see which fibers we would be interrupting when we did capsulotomy. So you can see here, this is a sum. It's an average of the lesions of our the patients in our trial. You can see here the region of interest, and when he plotted that to a normative DTI atlas, what we found was that our lesions interrupted fibers going basically to the ventral medial prefrontal cortex, some to the orbitofrontal cortex, a lot to the medial thalamus. So this is more or less the fibers we expected to lesion with capsulotomy. So what do I think about FUS? Very early days. I think it's promising. It's a promising therapy. Having said that, I've seen patients with capsulotomy radiofrequency, and I also think it's promising. And I follow some of the work that Euripides and Antonio Carlos and Dr. Manuel and all the investigators are doing at the University of Sao Paulo, Alexandra and Antonio, with gamma knife, and the patients seem to do well as well. So capsulotomy is a good procedure, especially for obsessive compulsive disorder, in my view. We need additional studies, we need a larger number of patients, etc. But I think it's a promising procedure. So with that, I'd like to thank you. I'll conclude, just acknowledge my colleagues here at Sunnybrook. There's 3 people that lead the Harquail Center, so Nir, Peter, and myself. So if somebody wants to get in touch, this is my email. And with this, I'd like to thank you.
Okay, thank you very much, Clement. Objective, excellent lecture, very provocative. Thank you very much. Before today we will have a very special patient. Professor Antonio Carlos Lopes is a professor in the Psychiatry Institute of Hospital das Clínicas, Universidade de São Paulo. Professor Antonio Carlos, welcome to our meeting, and I will wait. I beg you to wait for comments and questions right after moderators. This is how we do with such an important guest like you. Now I would like to invite our moderators for comments and questions. First of all, Professor José Osvaldo.
Thank you, Paulo. Congratulations on brilliant presentation. This matter has always been controversial and still is. I want to ask you if non-ablative methods like DBS can find less barriers and criticism from lay society. After all, neuromodulation promise to preserve the nervous system and offer a reversible treatment option. So what do you think about Clement?
I think, yes, you're right. I heard that from big people in the field, and I agree. With neuromodulation, we got a second chance to do psychiatric trials. They're certainly less resistant from the I think, from everybody, from the community, from other physicians, from different psychiatrists. Still there's resistance, but less than lesions. With non-incision modalities like ultrasound and gamma knife, I think the resistance to ablative procedures is dropping as well. So I think there's a chance that we are going to be seeing more and more of these procedures. The resistance to DBS, for a lot of it, is because of the negative trials that we had in the field of depression. Bear in mind, I think for obsessive compulsive disorder, for example, it's one of the only fields where we have class 1 evidence suggesting that DBS works well for OCD. So I think there's less resistance, Joseph, for sure.
And about abstinence of neuromodulation, what do you think about the risk?
You're talking about depression, or you're talking about drugs?
Abstinence of neuromodulation, of electrical stimulation by interruption of function
Yeah.
of the device.
My personal impression, okay? So don't take it as a general piece of word, or a lot of people don't think it like that. Some people claim that the effects of DBS, they wane like this. I think with psychiatry, you induce a lot of plasticity in several brain circuits. And the patients I've seen, and we did a few studies in which we discontinued stimulation so that we could see the patients getting worse. And this doesn't seem to be the case. So we have 3 or 4 patients in Toronto that we did this in depression. For example, we discontinued stimulation. They got a little worse, but then they got better again. So I don't think you crash like Parkinson's disease, where you turn it off and the patients get worse all of a sudden, then you need emergency battery treatments. I haven't seen that. I know some people report it, but I think it's more like dystonia, where you have some time for the symptoms to recur. That's my impression. So some people seem to believe that the effects are very acute when you discontinue. The ones I've seen, when the people get worse, they certainly get worse over time, but it's not something that you have an abstinence like this. For drug addiction, I think this is a very complex field. We are doing a study with alcohol here in Toronto. We have a DBS being done for alcohol. It's really complex. So yeah, really complex. So it brings to, why do you drink? Do you drink to compensate for something that's social? Do you drink because you're depressed? Do you drink because you have some social economic problems? Do you drink as a rewarding mechanism? So it's so complicated. It's really not easy. So we're still learning from this patient. So I hope to have more data soon. But in my view, the experience of seeing the patients, I think, is more complicated than depression or OCD. Alcohol is not simple at all.
Thank you very much. O seu microfone está desligado. Your sound is off.
Sorry. We have some problem with the video. Thank you, Osvaldo. Thank you very much. And I'm stressed a little, but now we fix it. Thank you again. I would like to invite now Professor Luis Carlos Modesto.
Well, thank you very much, Paulo Breiner. It's a great honor to be here with the masters. I owe a lot of what I do to what I've learned from you guys. Well, it's a great presentation, and it makes us think a lot. I mean, I have some questions. How far is your target, your ventral internal capsule target? How far is it from accumbens? When you measure this best fiber tract spot?
We are dorsal to the accumbens. We are more or less in the ventral side of the gamma knife target.
Okay.
More or less.
Okay. And another question is, have you, because I deal with so much with PTSD patients with pain, have you measured anything about their response to pain, or their autonomic response, if they have more parasympathetic activity or something?
To be honest, Luis, we have this in the trial. I don't know how to interpret the data. I collected, I'll be very honest with you. I mean, I have the data, I don't know how to interpret it. So what we're doing now, we're collecting data from normal individuals, normal people, age-matched controls, so that they can understand a little bit how that data can be interpreted. So we did skin conductance responses. So sweating responses in a conditioning paradigm. But this is a very exploratory trial, right? So we have one patient, we treated 2 more now. So it's very exploratory so far.
Okay, and
But I
also,
suspect that they may have autonomic changes as well, or improvement in autonomic changes.
yeah, I was thinking maybe that if you could find, you were talking about the predictors, maybe response, because you've already trying cortical sizes and fiber dimensions, so maybe, and drug response, so maybe the autonomic response and pain response could be a predictor of your response, of your responders.
There are certainly autonomic, there are certainly people looking at that. Helen is looking at skin conductance response, sweating response in the hand. In the TMS field, in transcranial magnetic stimulation, some people are looking at skin responses. They're looking at heart rate variability. So patients with depression, they have a less heart rate variability. When you do TMS, when you treat with antidepressants, they increase the heart rate variability. So some people are trying to see if that predicts response in long term. So that's been done with other neuromodulation studies. The problem with DBS and psychiatry is that our trials are so small. You have 5 patients, 6 patients. Yeah. And getting funding now is so, it's a crazy field. It's difficult to get funding now to do studies. So yeah. And if you don't have a lot of patients, it's difficult to find a predictor, really difficult.
Well, thank you. Thank you very much.
Okay, now I would like to invite the Professor Rodrigo Labruna. Professor Labruna.
Rodrigo, your mix.
Microphone. The speaker is closed, Rodrigo.
Is it working? Yeah?
Perfectly.
Yeah. Congrats, Dr. Clement, for your lecture. I thank you. I've seen so many lectures done by Professor Clement. And congrats, and thank you to participate and learn about the state of the art of researches in psychiatric surgery. Well, I wonder, after your considerations in researching, I wonder about the time we are going to have the DBS for mental disturbance applied in our daily clinical practice. So my question is, how is the movement there in Canada or US concerning the reborn or re-emergence of psychosurgery? Is this growing up or not?
The interest is good. The movement, I wouldn't say is growing. There was a lot of enthusiasm before the negative studies that I showed you. For example, in Canada, you can do lesions. You can do not ultrasound. You can do radiofrequency, cingulotomies, capsulotomies. Those lesions are approved. You can do as a regular surgical procedure. DBS is not, Health Canada does not approve it as a therapy. So it's difficult for you to build up a program of DBS. You can do it. Everything that I showed you that I do here at Sunnybrook is research. In the States, DBS is approved for OCD. So you can do OCD surgery, if you will. You're going to have to fight with insurance companies. According to some colleagues of mine, that what they tell me is that they have to fight to have the DBS paid by insurance companies, but you can do. So the FDA approved under certain conditions. So for Tourette's, you can implant. For depression, I think there's a little more is going to be required. So there's negotiations on which kind of data is going to be enough to approve DBS for depression. So are we going to need another randomized clinical trial implanting the electrodes and just comparing sham stimulation versus active stimulation? Or can you do a different design? Can you compare stimulation with a repository of patients? Again, this is my view, Rodrigo, my view. Like, this is me.
Yeah.
I think the electrodes in the brain are part of the therapy. So I think just putting electrodes, they make changes. So they change your brain. Not only in the target site, a little bit of inflammation, not that. They change activity at a distance from the target. And that's based on rodent studies that I have in my lab. So I show that you implant electrodes in the frontal cortex or in the hypothalamus, and then you change receptor levels in the amygdala, or you change volume in the hippocampus. So far away, that thing in your brain makes a difference. So I don't think that's an inert part of hardware that sits there and does nothing. So your brain reacts to that. So every time that I do a test in rats, normal behavior is here, DBS is here, sham is here. So every time. Yeah. So to me, I mean, with Parkinson's, we're lucky because the effects are so acute. So you turn on and off and you see a difference. But with psychiatry, taking that long and the DBS being a part, the electrode being a part of the therapy, I don't know. We may have to come up with a different sort of arrangement. So comparing with historical controls, but I mean, convincing the FDA that comparing DBS active stimulation with historical controls is enough to approve a therapy. It's a hard sell too. I agree that it's too much to ask, but if we start comparing always active versus sham stimulation, we have to do a very good job in my view. We have to recognize who responds to DBS, what's the optimal. We have to know everything before we embark in a new trial. That's my view. So you can do DBS for OCD in the States. You cannot do any other things in terms of psychiatry. You can do lesions in the States. Here in Canada, you can do lesions. Depending on your program, you can do DBS. I think in Brazil, you have some regulations that are a little strict. And it doesn't matter which country, you have to follow your regulations. So just follow what the government says or your medical society says, and you have to do that.
Okay, I congratulate you for your research. Thank you very much. But I'm always concerned about our clinical daily practice. Yeah, but thank you very much and congrats.
Thank you.
Okay. Finally, thank you, Professor Rodrigo. Finally, I would like to invite Professor Antonio Carlos Lopes, our special guest. Professor.
Thank you for the invitation of talking today with you. Well, I would like just to introduce the start saying that I have been working for around 20 years with the screening assessment of OCD patients for psychiatric surgeries. And I just think that there are two main issues that we must take into account when we are dealing with these patients. First, the question of the selection of patients and also the question of the follow-up. So for the question of the selection, we must always remember that patients who are referred to psychiatric service have comorbidities. They have psychiatric comorbidities, and this most of the times this is the rule. This is not the exception. And it does seem to me that this is a very important issue that may have an important influence on the outcomes of the surgery. For example, if you take OCD patients, when these patients have hoarding symptoms, when they collect objects a lot, or when they have comorbid, severe obsessive-compulsive personality disorder, this seems to be correlated to bad outcomes after surgery, at least for gamma knife surgery. So that this may have an important impact on the outcomes after they do surgery. And so we must also take into account that comorbidity is really important when you are referring these patients, when you are selecting these patients. So one important question is that we really need to have an experienced psychiatrist and a team that may help us restrict who is the ideal patient for surgery. Not every patient who has OCD or who has depression, even though he may say that he has a refractory OCD or refractory depression, this is not enough. We must better characterize who is this patient and what does this patient have more than just OCD or more than just depression. What else does he have? This is an issue.
Okay, so should I answer now or and then?
Yes, please.
Okay, so the way it works here at our center is really cool. It's nice, and I'll tell you why, because I think it's nice. We established a center that it's a neuromodulation center. So we deliver TMS and other non-invasive modalities, and we also do DBS, focus ultrasound. So when psychiatrists in the community and other psychiatrists refer patients to our center, they refer to a neuromodulation center. And then they're going to be triaged by psychiatrists. Obviously, it's not me. So the patients, they usually are seen by at least 2 psychiatrists in our center. And they are going to agree whether the patient is refractory or anything else needs to be done for this patient in terms of clinical work or clinical medication trials, etc., or extra psychotherapy, CBT, etc., etc. Once the psychiatrists are okay, then they refer the patient to us. And certainly, and then I have to agree with you, I cannot agree more. I mean, the patients that are come as a refractory patient, they are they have multiple diagnoses. So certainly, a lot of them, they have personality disorders. We try to avoid, when we track, when you tag a personality disorder and it's very prominent, then we say you're not a surgical candidate. So we try to exclude those. Sometimes, or a lot of times, you do not perceive before surgery, and you end up operating, the patient doesn't get better, and then you say, oh, the patient had a personality problem. So what I can tell you, we have 2 psychiatrists that screen the patients before they come to us. I don't have a psychiatric, I am not a psychiatrist, so diagnosing for me is not good, but I have an eye to say this patient has something funny that I don't like quite a lot. You know, sometimes I cannot put in words, but then the psychiatrist says, oh, there's this and this and this. Okay, but when the patient is a clear, very good surgical candidate, the patient comes to us and I say, okay, I like this person. But psychiatrists, certainly they have all the exclusion, and they have to have a consensus here before the patients are referred to surgery. I can tell you about that PTSD patient, because in my naive sort of surgical mentality, I was going to design a trial and get a patient with 0 trauma. The patient suffers a trauma and develops PTSD. These patients, they get better with medications. So we ended up recruiting patients with very complex PTSD that suffered many years of abuse and then had an acute trauma and aggravation of the scenario and depression and this. And surgery, there's no simple diagnosis in surgery. Very, very difficult for this to happen. At least, I mean, I haven't seen many. You try to exclude when it's an overt personality problem, then we don't treat, we don't operate, we don't offer surgery, because you know these patients are not going to do well, right?
My personal experience is that it's impossible to exclude everything.
Yeah.
You can't exclude everything, but if the patient has or sometimes even more severe diagnosis, except OCD or depression, then he probably should be excluded if it's too much severe. Yeah, that's my impression, at least.
Yeah, severity hasn't been a problem to us. We treat patients with all degrees of severity. If they're severe, they're candidates. But what you're saying, for example, we have a lot of surgeons in the audience. It's like when you do pain surgery, when you say, I'm going to treat a patient with pain, chronic pain, without any psychosocial overlay. I don't know if this exists. I mean, a patient with chronic pain with not a bit of psychiatric component. If I have chronic pain for 20 years, I'll have psychiatric diagnosis. It's not possible to. It's very difficult to compose. You know, like it's difficult, right? So it's like psychiatry the same. Like a lot of them have a mixed diagnosis, and we try to exclude overt personality problems, but sometimes we only tag them afterwards, and it happened before, and then the patients will get better, and you realize why later. Yeah.
And just a final question or issue that I think that's important is that many studies have seen what happens to patients in terms of the improvement of symptoms, just improvement of symptoms, and they don't take into account other things like functionality or even quality of life I've seen some patients who did improve their OCD symptoms or even depression symptoms, but they didn't do anything else in their lives. So they didn't work, they didn't have a job, they didn't have a girlfriend, they didn't have anything, they couldn't have anything, even though they worked better. So isn't this an issue?
We have both ways. We have patients who improve in scales and quality of life doesn't improve much. And we have the other way around. We have patients that, how are you doing? All the same. Oh, but now this week I went and I played tennis. Like, or I fixed my kitchen. Like, how are you fixing your kitchen if you're the same? You know, you have these two scenarios. You have this in the pain field as well. So you have sometimes you treat a patient with pain. How's your pain? It's always VAS 6, 6, 6, 6. Okay, but this, then you talk to the husband or the wife and say, oh, but this week the patient did this and this and this much more. And then you realize an improvement in quality of life without pain scores changing. I've seen patients with psychiatric disorders and that were treated with surgery. They claim they're the same, but they're doing far more in the house and they're assuming more chores and they're doing more. And I've seen patients improving in scales that do not improve quality of life. And in OCD, you see that much more. Because the patient can tell you, oh, my OCD is better. I used to have this compulsion or this obsession 60% of the time. Now I have 40% of the time. For example, just a generic example, that doesn't amount in anything useful in terms of quality of life. The patient doesn't have it's a substantial improvement in OCD, but not, it doesn't reflect an improvement in quality of life. So I've seen both.
Perfect. Good.
Great. Okay, I would like to invite Antonio Almeida, Professor Antonio Almeida, for questions and comments. And after that, we will have another round of comments and questions with everybody. Professor Antonio Almeida.
Hello, Clement. Well, actually, everybody agrees that the problem is with selection of patients. And from where do you think we'll come to answer to this question? I mean, it's from radiology, from better psychiatric assessments. Where do you come? Where do you think we'll come from?
It's a very difficult question. So I'll have a very tangential answer, okay? So you talk to surgeons, they seem to think that it's psychiatric indication. You talk to psychiatrists, they seem to think that it's the targeting. I think we have to get together and discuss, because only when you look at, you realize things that psychiatrists don't realize, and psychiatrists for sure realize things that you don't know. So the nice thing about interacting with psychiatrists, and I've been working with Antonio in some projects for some years now, and the nice thing is that there's a clear boundary of respect. So psychiatrists, they say, I know up to here, but surgeons have this to add. And surgeons for sure know, they tell you, I know up to here. And psychiatrists, they know like a lot more than we do here. So the interaction is key. So you have to have a very good relationship with your team. So psychiatrists, psychologists, if you have a person that's doing imaging, this is great. So the team has to work together. And if possible, if you have a multidisciplinary clinic where the patient comes and it's seen by everybody together, this is the ideal scenario, in my view, my ideal scenario.
But do you think they will find any hallmark in their image, for instance, the tractography, when the patient has a certain image, they will have a better prognosis, or no?
It's not the place. Might, but I don't think it's going to be that easy. I don't think tractography, for example, there's a lot of artifacts, and it's very difficult to put the weight of tracks into the context. So, for example, if you get two patients and you find a target that's or a track that's this tick versus this tick, is this real? Is an artifact? Can you attribute to reality? Tractography is a very nice technique, but it has limitations. So I think it's a very good tool, but I think there's something in the clinical phenotype of patients that we're not realizing. And as I showed you in some slides, I mean, some patients with depression, they get better when you do the on and off sort of analysis. The problem is, who are these patients? How can we track these patients? When you see enough, you get a hint. You say, something here shows me that this patient is going to get better. But so far, in my neurosurgical language, I cannot put into words. I cannot say, oh, this patient has this kind of feature, or this kind of psychiatric diagnosis that I cannot do that, at least. So, but you have to combine with a psychiatrist because they have the language. You don't have the language to discuss this kind of issues. It's very crucial. You may even understand you may understand more or less what you're talking, but they have the appropriate means of putting into words and addressing the problem in a more in-depth sort of way. You need psychiatry. Like, it's all together. Like, we have to gather as a group for sure.
Okay, thank you.
Great. I would like to open the microphone to all moderators and our special guest to any other question. And after that, we have some question from audience. Please.
Can you tell us about what do we know from transcranial stimulation to select patients and targets for OCD, depression, and PTSD?
I don't think there's any big study that did that, especially because the TMS targets are you can do deep TMS, but they're superficial so far. There was the idea that you could do deep TMS in the subgenial region and try to see if that would predict response to depression. I don't know if anybody did that. I don't know if Antonio has experience in OCD. It's a good idea, but I'm not sure if people did that so far.
Okay.
I'm just going to read 2 questions here that I'm seeing. So one is, did you access the effects of directional stimulation or anodic stimulation in your studies? Anodic, no. Directional, the only time I use is in that PTSD trial that I showed you. We're using directional stimulation so that we can stimulate that blueprint and the fibers going to the uncinate fasciculus. So we selected the directional lead exactly because we wanted to do that. So that's the only instance in which I did that. There's another question by Fabio Godinho. If we reposition any leads, I would just quote a professor of us, because Fabio and I did residency together. If you didn't have any complications, either you're lying or you didn't do enough. So we did reposition a few leads. So we had a problem with the merging of imaging in one case, and the leads were off. So we had to reposition leads. We had to reposition once, actually. We had one lead that got pulled, and the patient has OCD, and he has one lead in the target and one lead high above, and he's doing well, so we never repositioned. So we had a few instances where we had complications like that. But not because of target. I don't know if this is what Fabio meant. So, oh, I know, I wanted to place the electrode here, and I believe that it's 1 millimeter off. We didn't do that. Like that we never did. We did it because of small problems that occur in the research.
Great. We have some questions from audience. Professor, how do you think about VNS for depression today and the near future?
I don't have experience with VNS for depression. I talked to a few colleagues that participate in some of the trials. They're not that enthusiastic. Having said that, the procedure was approved to some extent, so you can do it. But I don't know anybody actively doing this in clinical practice. I don't know, but people may do and may have very good results.
Another question. Is DBS completely different from traditional psychosurgery? And should it receive a different ethical and regulatory assessments?
It's a very, very, very broad and difficult question to answer. So from a mechanistic standpoint, it is different. So if you do a lesion or if you stimulate, it's a different story. So especially because when you do psychiatric surgery, you're talking a lot about fiber surgeries. So you're not, usually your targets are fiber tracts. So for the anterior limb of the internal capsule, the fibers of the subgenial region, the cingulate bundle when you do a cingulotomy, etc. So you're talking about fibers. When you use DBS to stimulate these fibers, when you do lesions, you lesion the fibers. But having said that, depending on how you stimulate, you may jam the information conducted by the fibers, and then you would create a functional lesion. And if you use very, very high frequency, above 1,000, 2,000 hertz, you may even jam for real the fibers and they don't propagate inflammation anymore. But in principle, I think those are two different therapies. So stimulate is one thing, lesion is another thing. In some instances, the outcome is the same. So you stimulate a new lesion, you have the same clinical or behavioral effect, but there are different therapies. As for ethics, to be very, very honest, I mean, I've been following patients with capsulotomy, cingulotomy. I don't have experience with subcaudate tractotomy. I haven't seen patients, but with capsulotomy, cingulotomy, Antonio's here, he also has a lot of experience. I haven't seen a lot of side effects, you know, like people that, the ones that people claim in the past, oh, you have this inhibition and this and that, and patients have urinary incontinence. I've seen one urinary incontinence that this was when I was in another service, resolved very quickly. Like in a day, this was resolved. And I haven't seen a lot of issues, you know, it's, so I don't know if a different, I don't think you have to have a different ethical process for both. I mean, the patients are the same. The issues with competence to give consent are the same. The problems and the disorders are the same. It's just a different technique to treat the same disorders. I think the consent and the ethical process should be similar. My view, again, me, my personal intake, my personal take on this.
Sorry. Great.
I have a little question.
Please.
Clement, could you explain something about why post-traumatic amnesia is a contraindication for OCD control surgery, and what kind of amnesia? Temporary too?
I don't know if it's a contraindication. I mean, we never experience. I don't think I confront a patient with post-traumatic amnesia with OCD that was operated. You have experience, Antonio, with this? I don't know. I've never seen that, Jose.
I read in your paper of DBS for OCD, and have a plate that is traumatic amnesia inside the exclusion criteria.
No, I don't know. I'll recheck the papers, but it doesn't ring a bell or it doesn't call my attention. I don't know if I have experience, Antonio, because these patients usually don't have amnesia. Patients with OCD, it's not a complaint that they have.
No,
they really don't have this kind of complaint. They don't have it. I don't know why it was cited.
Great discussion. We have another question, high level like the another one. This is to the Professor Antonio Carlos. In your opinion, how can informed consent help or hinder the indication of neurosurgery for mental disorder, Professor Antonio Carlos?
I think that the consent form should always make very clear to the patient the possible benefits and the risks for the procedure. It should be talking in a very clear language to the patient. The question is, some patients do have some view of surgery as if it were some kind of miraculous treatment, which is not true. And I think that it's always good to show the patient that, okay, it can bring a benefit, but this is not a miracle. It has to be very clearly stated to the patient. And this must be very much well stated to the family, to family members, which some even more patients than the patient himself. So I think it should be clearly stated. If it's clearly stated, there will be no problem. That's what it seems to me.
I agree with Antonio. And one thing that we tell the families and the patient is that probably the most, it's not a side effect, but we frame it as if it is a side effect. It's not a side effect, but we say the biggest deceiving aspect of the surgery is that You do all this process. You put the frame, you undergo surgery, DBS or capsulotomy or FUS or any surgery. You do all the process, you undergo surgery, you have all the follow-up, and in the end, you don't get better. And this is going to happen in 50% of the time. So you have to tell this to the patient. So there's a high chance, or at least a 50% chance, that you're going to undergo all this process, and in the end, you're not going to get better. So this is very deceiving for people sometimes, especially in psychiatry, because a lot of them, they have been treated with several medications and psychotherapy, and they face the surgery as if it was a last resort. So one thing we tell the families is that now you're doing surgery is the beginning of a new era. So after surgery, it may be that you're not going to be better by itself, but you're going to be able to add some psychotherapy and get better. So you don't discourage the patients, but you clearly explain, as Antonio was saying, that you may do the whole procedure and you may not get better with the procedure by itself. This has to be very clearly stated.
Yes, I agree. I think you must give the patient realistic expectations regarding the surgical procedure, how it can help and how it cannot help the patient. Another question is that you must always tell the patient that he must go on with all other treatments.
Exactly.
You should not quit the other treatments, which, in fact, the surgeon may act as an augmentation strategy to all other treatments.
That's a very good point, Antonio. It's exactly the case. So patients, they very commonly come to you and say, am I going to be able to decrease my medications? The answer is always, we don't know, probably not. This is an add-on treatment. So we're not going to cure you. This is going to be a treatment to add to the treatments that you're currently using. So I agree with Antonio 100%.
Great discussion. Another question from audience. Professor Clement, what do you consider the ideal target for in OCD?
I'm sorry, Paulo, it broke to me. So can you repeat the question?
Yes, is that what you consider the ideal target for OCD?
The ideal target?
For OCD.
For OCD, there's 3 targets or 4 being studied. So the most common ones are the anterior limb of the internal capsule. There's the subthalamic nucleus, medial aspect of the subthalamic nucleus. There's inferior thalamic peduncle, and there's some other targets. I'm not going to talk about those. So we have, we as a field, neurosurgery, has more experience with the anterior capsule. So if you talk to most surgeons, they're going to say, I do DBS or surgery or capsulotomy. Internal capsule is the target that comes to mind. That said, the highest degree of evidence suggesting that DBS for OCD is in the subthalamic nucleus. So we have class 1 evidence suggesting that STN DBS improves OCD. But most surgeons in the field do stimulation of the internal capsule. Only a few centers do inferior thalamic peduncle.
Professor Labruna?
Yeah, I agree with Dr. Clement when he says the psychiatric surgery is a benefit for the patient, because when you offer a 50% of chance of becoming better, is much better than the 0% the family got so far. That's why I think it justifies the psychiatric neurosurgery.
I agree, Rodrigo. I've seen enough patients to convince me that this works. It doesn't work for everybody. A lot of patients don't get better, but some patients get really, really, really much better than they were before. And yeah. I've seen enough cases of batteries dying, the patient doesn't realize, and it comes back and says, oh, I'm not feeling good, I'm not feeling well, blah, 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 my depression's coming back, I don't know what's going on. And then you check the battery is expiring. And then you change the battery, you recapture the benefits. I've seen this too. So I think we're just missing a way of understanding who's going to benefit from surgery. In OCD, yeah, as Antonio was saying, there's some features that we know that do not forecast a good prognosis. For example, if the patient's a hoarder, hoarding doesn't do well with surgery. So if hoarding is the main complaint, you avoid surgery, for example. But in depression and some other conditions, we don't have this kind of prognostic feature. But I agree.
Yeah. Thank you.
Thank you, everyone. Now we are finishing. Our time is finished, and I would like to thank you, everyone, for your time, for your presentation. Congratulations, Dr. Clement, and ask our president, Dr. Antonio Almeida, to close remarks.
Well, guys, it was a very nice time we had here. It was a great lecture, a great discussion. Dr. Antonio Carlos, it was good to have you here. It's really necessary to have a psychiatry among us. It's as Clement said, neurosurgery is just a part of the problem or the solution. We really need some clinicals in the middle of the way between us and the patients. And all I have to say is, great, have a good night, and next week we'll be here again with another topic. So, bye-bye.
Thanks very much.
Bye. Thank you very much.
Thank you.
Thank you very much.
Nice to see everyone.
Bye.
Clement?
Yes.
I have a message for you from an assistant who was looking for a mice lost in your search. He returned to home safely.
Mouse lost my research.
It's a joke.
Oh yeah.
You remember?
I've seen once or twice. You cannot say that. We captured them.
Yes.
Yeah. Oh yes, remember. No, we captured them. It was interesting.
Thank you very much again. It was brilliant. One time more.
Okay, bye.
Bye everyone. Best wishes.
Nice to see you. Nice to see everyone.
See you too.
Everybody.
Bye. Thank you.
Great.
Bye-bye.
Bye-bye.